Okay, good night.
Good night. Night.
Good night, everybody, and very night in Australia for Michael. Tonight we are very grateful that we got very international speakers from Australia and from India, Malaysia. We will going to have the fourth CARS international webinar about a sharp focus on safety, protecting staff to protect patients. It's an honor to have you all here. Before we dive in, let's take a moment to pray for our CARS surveyors, Dr. Lia Imelda and Dr. Nur Fajri from Aceh Tamiang, who have been missing for 4 days in the Great Aceh floods. May they be safe and always under the protection of God, the Almighty. Our thoughts are with them and their families. As part of our collaboration between CARS, PCCI, Patient Centered Care Institute, ASQA, Asian Society for Quality in Healthcare, and also the Staff and Patient Safety Australia, we committed to advance healthcare quality in Indonesia. Through PCCI focus on patient-centered care, we believe that putting patients at the heart of our service will lead to a safer, more compassionate care. Patient-centered care is not just an approach, it's a movement towards more human and effective health service. We are absolutely delightful
Sizin için açtım.
to
Türkiye
have
deli gibi geldi.
four
Onun için.
distinguished speakers.
No.
Dr. Henny, your computer has gone on mute.
Yes.
Unmute, Pak.
Oh,
Thank you.
sorry. We absolutely delight to have our distinguished speakers today, Dr. Michael Sinnott, MBBS, FACEM, FRACP, Associate Professor at Queensland University of Technology, Australia. Also, Associate Professor and Head of the Department of Pharmacology in Bharat Institution, India, Dr. Shreya Singh, PhD. We thank both of them for sharing their expertise. We'll explore the vital connection between staff safety and patient safety, latest strategies for preventing sharp injuries, and how to embed one safe culture across health systems. This event is free for all, and you receive a certificate for the attendance. Me, I'm Dr. Hani, become your moderator. Please join us for this very important meeting. Thank you. The next session, we will hear Dr. Sutoto to have his opening speech. Please do.
Good evening, esteemed colleague, healthcare professional, and friends from all over Indonesia and Asia. On behalf of CARS, it is my great honor and pleasure to extend a warm welcome to each of you at this international live webinar, a sharp focus on safety, protecting staff to protect patients. In the noble mission of healthcare, our staff are our most valuable asset. When they are safe, empowered, and protected, they provide the exceptional care that our patients deserve. Safety is indeed not just a task, but a culture we must build together. Tonight, we are exceptionally fortunate to be guided by two brilliant minds who are pioneers in this field. So, Dr. Michael Sinot, we extend our deepest gratitude. Thank you for sharing extensive expertise and powerful insight on clinical safety and shock injury prevention. Your work in emergency medicine and as an associate professor at the Queensland University of Technology provide an invaluable perspective that will undoubtedly inspire us all. And to Dr. Shreya Singh, Associate Professor and the Head of Department of Pharmacology, Bharat Institute, we express our sincere appreciation. Thank you for joining us and for your dedication to advancing medical knowledge through pharmacology. Your research and leadership at Bharat Institute are crucial in linking scientific evidence to practical safety implementation. To both of our distinguished speakers, we are truly thankful for your commitment and advancing this critical cause. Your presence here elevate our discussion and strengthen our collective result. To all our participants, your engagement is vital. Let us learn, share, and be inspired to champion a culture of safety within our own institution. Thank you for your participation. Let's begin the enlightening journey. Thank you very much. Back to you, Dr. Hani.
Thank you very much, Dr. Sutoto, our Chief Executive Leader from CARS. We will thank also for the foreign participants from Turkey, from India, from Taiwan, and from Australia. And before we start, maybe Dr. Johnny will have a prayer for us.
Okay, thank you, Dr. Hani. Ladies and gentlemen, especially for our distinguished guests from other country, may allow me to lead this praying in Islamic way. Bismillahirrahmanirrahim. In the name of Allah, the most gracious, the most merciful. O Allah, Lord of all worlds, we gather here today in humility and gratitude, seeking your guidance and blessing upon this knowledge-sharing session of PCCI. O Allah, you are the source of wisdom, safety, and compassion. Grant us clarity of mind and purity of intention, so that every discussion, every idea, and every insight shared today may bring benefit to our hospital, our staff, and the patient under our care. Ya Allah, bless this program titled A Sharp Focus on Safety, Protecting Staff to Protect Patients. Strengthen in our hearts in the understanding that safeguarding our healthcare workers in a sacred responsibility and a pathway of protecting every life entrusted to us. O Allah, guide our leaders, clinicians, nurses, and all healthcare workers with your light and wisdom. Protect them from harm, fatigue, and uncertainty. Grant them patience, resilience, and sincerity in serving humanity. Ya Rab, instill in us the courage to improve, the humility to learn from the other, for another, and the commitment to uphold safety and quality in every action we take. O Allah, make this session fruitful. Let it inspire new solution, strengthen collaboration, and become a source of goodness for our institution, our communities, and our nation. Forgive our shortcomings, accept our efforts and acts of service, and bless us with success in the world and hereafter. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina azabannar. O Lord, grant us goodness in this world and goodness in the hereafter, and protect us from the torment of the fire. Amin. Ya Rabbal Alamin. Thank you, Nadim.
Thank you, Dr. Johnny. So now we will start with our most precious presentation from our both professors, from Dr. Michael Sinnott from Australia and Dr. Sriya Singh, both associate professors in their field. Please do.
Thank you, Dr. Hani, Dr. Suto, and Dr. Johnny. On behalf of Sharon, I would like to say that we are both very honoured to be invited to do this session, and we look forward to collaborating with everybody during the question and answer session at the end. Please let me share my screen. And that's shared now.
Yes.
Okay.
You can see my screen.
Yes.
Thank you. I would like to start this presentation on a sharp focus on safety, protecting staff to protect patients by acknowledging the Turrbal and Yagara people, the traditional owners of the lands on which our organisation is based. I would like to pay our respect to their elders, past, present and emerging. Like CARS, staff and patient safety is dedicated to improving staff safety, and in doing so, we know that this will also improve patient safety. During this talk, we will share with you our ultimate goal of creating one safe culture for all, staff and patients. Today's session is going to be a little bit different. We will start with an icebreaker activity to, as Shreya says, to get your competitive juices flowing. For this, fix this activity, we will ask you to look at the poster on the next screen. The poster has an image of an operating room setup with several safety flaws. You will have a few minutes to look at the picture and identify these flaws. Then I will ask you to raise your virtual hand and I'll call upon you to tell us your name and the flaw that you have identified. Please just share one flaw at a time so we can get many people to participate. Remember, please state your name first and then name the flaw. So everybody could have a look at the image on the screen and look to see what you think is bad. And when you've spotted a couple of things, if you put your hand up, and I might get Dr. Hani to ask people one at a time to share one of the flaws they've seen. Thanks, Dr. Hani.
Yes. Thank you, dear friends. Please see what's different, what's wrong with this picture, and put on the notes. Put what do you find it's different, what's not usual in the picture. Please put your name and what you get. Put it in the chat. Come on.
Doc.
Rita, please come and talk.
Thank you very much. One of the team is exhausted. It's danger for the patient.
Yeah, very good. Anybody else? Anything? Dr. Nico?
Burnout.
The meeting group.
Burnout.
Burnout.
Yes.
See, burnout. Okay. Anyone more?
No masker.
Yes.
No masker. Okay, no masker.
They are tired.
What is? They are tired. Okay, they are tired.
One of
Okay,
the
what
doctor,
else?
one of the doctor using the flip flop.
Yes.
The doctor used
Flip flop. That is correct.
laptop.
Yeah.
He's playing with his mobile. What about the lamp, the operational lamp? Somebody see difference between the operation lamp?
Yes. One is off and one is on.
One is off and one is on. What about the screen, the blue screen between the doctors and the? Is it
Somebody
not
has also commented about the blood on the floor and the slippers that the doctor is wearing inside the theater. So that's a good notice, well noticed. Thank you.
Yes, very good, very sharp eyes. Anybody else?
No hand glove.
No hand gloves. Oh, yes, the operator doesn't use hand gloves. Very good. What else?
There's a blood on the floor.
There's blood on the floor. Yeah, okay.
One person with a hand glove touch another person.
Oh, yeah,
That's-
with hand glove.
Yeah.
He touched the elbow of the sleeping
Yes.
friends. I think it's enough, Michael.
Thank you very much. Before I go to the next slide, I would like to congratulate the diplomatic statement by one of the earlier speakers who said that one of the people was tired. To me, it looks like they're fast asleep, but saying they're tired is very diplomatic. Let's go through some of the safety flaws together. No trolley to sit the instruments on under the nurse. The person in green is asleep.
Yeah.
This person is, or these people are not wearing masks inside the sterile operating theatre, and neither is the nurse beside them. The nurse holding the instruments has another two flaws. She's not wearing a mask or hair covering. The surgeon is wearing thongs on his feet, not closed shoes. There is blood on the floor, which is a slip and infection control hazard. The electric cable is a trip hazard. The person at the back is holding scalpels in her hand, as is the surgeon. The person in the back is resting her gloved hand on the shoulder of her colleagues and therefore is no longer sterile. The light is not working.
Yes.
So when we had this poster designed, we thought there were about 12 or 13 flaws. When we presented it to the Victorian Nurses Association, they found another 5, and one of the senior nurses in Turkey found another one we'd missed. But thank you all for participating in that. Now that was a good way to set the scene to discuss today's topic, Shreya will start by telling you about our organisation, staffandpatientsafety.org. After that, we will give you a brief history on both patient safety and staff safety. In the next 2 sections, we will look at the big picture of staff safety and follow that up with a focus on sharp safety. Then we will share an overview of our global approach to improving staff safety, which will include case studies from Australia and the United States, and our global approach to managing these injuries. In the final 2 sections, we will share with you the latest evidence, the sharp safety guideline updates, and the core innovative tools that we have created to advocate for these updates. Shreya will complete the presentation with 2 key messages. Firstly, that we all need to work towards one safe culture for all. And secondly, the need for us to recognise that the next step to achieve this is to acknowledge and share that staff safety is the new standard of care. Starting off a little bit closer to our organisation and its main functions, I'll hand over to Shreya. Thank you.
Thank you, Michael. So a little bit about our organization. Staff and Patient Safety was established as an independent organization in 2008 to address gaps in research and implementation programs for staff and patient safety in healthcare facilities. So currently, we are working with like-minded clinical and educational leaders like yourselves to advocate for the physical and psychological safety in healthcare. Our approach considers the benefits of both high-level and individual interventions to make effective change. Staff and patient safety also provide students and healthcare professionals with essential education and training to ensure their continued safety. So, as an organization, in terms of our structure, SAPS has two arms. The first is advocacy, which includes advocating to reduce SHARP's injuries to staff. Our team has observed 4 key steps required to accomplish this goal of improving staff safety. Each step is aimed at a different level. We will be discussing each of these 4 levels later in the presentation. The second arm is the education arm, where we present and take part in conferences, seminars, and webinars like this evening. So, speaking about our advocacy efforts, we not only advocate for change, we actively review existing regulations. So, here are some of the highlights from our previous and ongoing advocacy projects. Staffandpatientsafety.org has made recommendations to the Occupational Safety and Health Administration in the USA to the letters of interpretation in 2005, in 2008, and in 2023. And most recently, we have collaborated with the Mexican Infection Control Professional Body to suggest updates to their SHARP safety guidelines. This persistent effort is leading to a change in legislation, which will make healthcare workers safer. So at staffandpatientsafety.org, we prioritize the education of clinicians and end users. We assist healthcare professionals to stay informed on the latest evidence on SHARP's incidences and ways on which they can improve their safety. So the topics we cover in our educational talks is including strategies for reducing risks in clinical settings, tips for improving reporting systems, and methods for creating a culture of safety across healthcare institutions. So here you see a list of our education engagements with annual conferences in the US for the Association of Registered Nurses and the Australian College of Operating Room Nurses. We have done workshops, and an example is one earlier this month in Turkey, which was on SHARP's injury risk reduction, and webinars on underreporting in both Hong Kong and the UK. So this continued for the European operating room nurses, for podiatrists, and for hospital staff nationally and internationally. Now, our education sessions cater to diverse regions, diverse facilities, and diverse organizations. As you can see, Staff and Patient Safety has actively participated in and attended various conferences to share valued insights and research on critical topics. I will now hand back to Michael.
Thank you, Shreya. Now that you know and understand what we do and why we do it, it would be easy for you to surmise that our core value is focusing on improving staff safety and how this is linked to improving patient safety. The landmark To Err is Human report was released in 1999. It stunned the world with its findings that between 44 and nearly 100,000 preventable deaths occurred in US hospitals every year. This led to significant reform in patient safety, and while the overall results have been disappointing, there have been some notable successes proving that the investment in safety can save lives. Similar findings have been reported in Australia. Let's refresh our memory of what has been done to reduce the preventable deaths and other medical errors. James Reason, a British psychologist, very quickly stated the obvious. Doctors and nurses don't go to work to deliberately hurt or kill patients, so something else must be happening. His theory was that we can't prevent adverse events by making humans perfect, so we need to change the conditions under which humans work, thus reducing the risk of errors occurring. He explained that what was going on was a series of systems errors and used the Swiss cheese model to explain this. The concept, beg your pardon, the concept shows that it is easy to shine a light through the holes in one piece of Swiss cheese. The hole represents an error. But for a patient to die or suffer significant morbidity, it usually means 4 or 5 errors have occurred at the same time. And as you can see from the Swiss cheese model, it is hard to shine a light through 5 pieces of cheese. That is, it's hard to line up the 5 holes. I'm sure some, if not most of you, have heard of this case that James Reason used to explain his model before. But let me paraphrase it a bit in the interest of time. A 22-year-old young man, Wayne Jowett, was in hospital in the UK. He had leukemia with cerebral metastases. The metastases were causing agonising headaches. This young man had an IV cannula in his forearm for chemotherapy and a cannula into his CSF for more powerful pain relief. On Sunday morning at 8 a.m, the new intern came up to the patient, said hello. He introduced himself and explained what he was going to do. But by accident, he injected the chemotherapy into the wrong cannula. It went into the CSF. The patient fitted and died a few days later. Why did this happen? The charge nurse was acting up as the ADON. The ward pharmacist was on holidays and her replacement had little or no experience with chemotherapy. The doctor was an intern, and like most of my colleagues, I would admit in hindsight, we didn't have much idea about what was going on practically back then. And it was a Sunday, so there was less staff around. Each one of these is represented by the hole in a piece of Swiss cheese. If any one of those 4 issues had not occurred, that is, one of the holes hadn't been plugged up, the mistake would have been picked up and prevented. The patient would not have died from a preventable adverse event. What can we learn from other industries? Dr. Jim Bajan was both a medical doctor and an astronaut. In fact, he was supposed to be on the Challenger flight, but was switched out just a few weeks before the launch. Many years ago, he gave a talk in Brisbane about his time at NASA when he was working with the Space Shuttle program. He told us how proud NASA was of their strict policies that prevented mistakes. In short, NASA had a long-established 3 strikes and you're out policy. When you made your first mistake, you got a day off. When you made your second mistake, you were suspended for 2 weeks. And when you made your third mistake, you were fired on the spot. So this meant that when the aircraft engineer who was tightening a bolt on the outside of the space shuttle made a mistake and turned the bolt 13 times instead of 12 times, he was faced with a dilemma. Did he tell his boss about the mistake and become one step closer to being sacked? Or did he shut up about it and hope for the best? Hope that the extra turn had not threaded the bolt and made the shuttle unsafe. However, after Alison, Krista, Gregory, Judith, Michael, Francis, and Ronald died in a fatal Challenger crash, things changed. NASA introduced a no-blame culture. So the aircraft engineer was encouraged to own up when he made a mistake. This meant his boss was firstly able to check that the bolt had not been threaded, and then the engineer, his boss, and other staff would try and work out how to prevent this mistake happening in the future. They came up with a pre-tension spanner to ensure every bolt was screwed in exactly the right number of times, eliminating the risk of human error. So NASA introduced a no-blame culture to improve safety. And this idea was also adopted, albeit later, by healthcare. But healthcare only adopted a no-blame culture for patient safety. They ignored staff safety, leading staff to operate in a self-blame or blameworthy culture in relation to injuries that they suffered personally. Now let's look at why hospital staff tend to ignore staff safety at an individual level. Firstly, denial. While we may be aware that the risk of contracting HIV from an infected patient is 1 in 300 and even higher for hepatitis C at 1 in 30, we all somehow assume that the infection will happen to someone else, and we deny that it could actually happen to us personally. Secondly, the concept of self-sacrifice. If you or I take a risk with our own safety for the benefit of our patients, we somehow feel like an even better person. In this cartoon, we see a child crying, not sick and definitely not dying. The man on the left rushes across hot coals in bare feet, almost certainly injuring himself badly. The lady on the right is smarter. She knows that the child is only crying, so she puts on her shoes before she walks across the coal to console the child. Both are safe. Thirdly, and most worryingly, is that when we are injured, we all too often blame ourselves. This in part explains why 50% of all sharps injuries still go unreported, and it also means that after an injury, we don't look at ways to prevent the injury recurring. A couple of years ago, I looked after one of our registrars who suffered a sharps injury in the emergency department. He came up to me, he looked a bit embarrassed and said to me, "It was my fault, I wasn't concentrating," meaning that he would never have another sharps injury because he would never lose concentration again. And this is an impossibility in a hectic ED. In another case, I was working in our observation bay when one of our nurses was kicked in the abdomen by a patient. The nurse was around 4 months pregnant. When I went to check on her, she was a bit teary and she said, "It was my fault, I got too close." This self-blame leads to a paradox of blameworthiness, which we published in the British Medical Journal well over a decade ago. It can be summarised as follows. Management instructs the staff to operate in a no-blame culture to improve patient safety. But management is happy to accept, even encourage our staff to operate in a blameworthy culture in relation to their own safety. Let's take a minute to think about this. Do you think it is possible for anyone to operate in two diametrically opposite mindsets at the same time? This leads to organisations prioritising patient safety and more or less ignoring staff safety. It also leads to individual clinicians ignoring their own safety and not repairing their injuries. I will hand over to Shreya to conduct the first of our thought experiments. Thanks, Shreya.
Thank you, Michael. So in our session, we've put a few thought experiments in to encourage engagement. As Dr. Sinnott just spoke about the blameworthy paradox, where there's a hypocritical stance on patient safety and staff safety, I wanted to ask the audience today whether you recognize the blameworthy paradox being played out or happening in some way in your workplace. You can answer by raising your hand right now, or you can answer in the chat box. And I'm happy for anyone to raise their hand and respond to this question. Dr. Hani, you're mute.
Yes, please do. Dear participants, raise your hand. Dr. Nico, Dr. Johnny.
The paradox, I think, is about you have a human error incident, but you have also system error incidents. So that's why David Marks put forward the just culture. Thank you.
Thank you, Dr. Nico. And you put it quite well about the just culture. And Michael will be discussing more about how we can reduce injuries and how we can mitigate this blameworthy culture. Over to you, Michael.
Thanks, Shreya. To illustrate how staff safety and patient safety are linked, it is sufficient for us to read these two quotes. The World Health Organization has stated No country, hospital or clinic can keep its patients safe unless it keeps its health workers safe. Protecting healthcare workers is key to ensuring a functioning health system. And Shaw et al. Published in the Lancet that there now needs to be universal recognition that health worker safety is patient safety. One cannot exist without the other. These publications highlight why it is important to integrate staff safety and patient safety. Hopefully, this will give people permission to prioritise their own personal safety. I understand that many of our audience have clinical backgrounds and many still practice. So I'd like to start this next section with a case study to put a human face to the facts and statistics that will follow. I would like to share a case report of a shaft injury from a used scalpel blade and invite you to keep this in mind when we go on to look at the theory and statistics related to staff safety. A 24-year-old female nurse suffered a penetrating injury to her right wrist while she was disconnecting the scalpel blade from its handle. She was holding the handle in her left hand, trying to disconnect it with a pair of artery forceps in her right hand. The blade slipped and penetrated the medial aspect of her right wrist. This resulted in severe pain and pulsatile bleeding. Immediately under local anaesthetic, the artery was ligated. This photo is an example of an ulnar artery surgical repair. Note, scalpels are second only to suture needles for the likelihood of a shaft injury in the operating theatre. Healthcare is now considered to be a high hazard workplace. In 2013, the Public Citizen, a not-for-profit organisation, published its seminal report in which they concluded that healthcare is a high hazard workplace. They found that in the US, there were 7 times as many musculoskeletal injuries in healthcare than in the manufacturing and the construction industries. Think nurses' backs. They found there were 7 times more assaults in healthcare than in the manufacturing and construction industries. Think drug and alcohol-affected patients and their relatives in the emergency department. Think all these things, but stop thinking that this is just a normal part of the job, something that people have to put up with. In Australia, the healthcare and social assistance sector is responsible for the highest number of occupational injuries and illnesses, almost 20% of all claims. This data is from 2023 and shows that healthcare is still a high hazard industry and that this is a global problem. This is not normal. This is not acceptable. In our home country, Australia, over 18,000 shaft injuries are estimated to occur every year, with 1 million injuries occurring across Europe and 385,000 in US hospitals. Despite sharp training and injury reporting requirements for hospitals, it is estimated that 50% of shaft injuries still go unreported. So the actual number of injuries could be much higher than the numbers on the screen that you see today. In this section, we will focus on the current status of shaft injuries. When we drill down into shaft injury, we find, as is demonstrated in the pie chart, that over 40% of all shaft injuries occur in the operating room. What is even more worrying is that the trend is going up in the operating rooms, not down as is the case in the rest of the hospital. The diagram on the right is a study done 10 years after the US legislation was passed to protect healthcare workers from shaft injuries. It shows the incidence of shaft injuries going down 31.6% in the hospital, which is great, but going up 6.5% in the operating room. The main culprits in the operating room are suture needles and scalpel blades. The world-renowned EpiNet surveillance system, which uses volunteered hospital shaft data from the US and Canada and many other countries, shows that the incidence of scalpel injuries are still rising. We compared data over a 10-year period between 2013 and 2023 and found injuries from disposable scalpels, including safety scalpels, went up 8-fold, and injuries from reusable scalpels, the incidence went up 5-fold. When we look into scalpel injuries in particular, a recent study published in 2020 from a large tertiary hospital in Brisbane looked at the likelihood of sharps injuries occurring per the number of sharps devices purchased. Scalpels caused 12.6 injuries per 100,000 scalpels purchased, while syringes and needles caused only 2.7 injuries for every 100,000 purchased. This means that scalpel injuries occurred around 5 times more commonly than syringe and needle injuries. This was second only to suture needle injuries, which occurred at a staggering rate of nearly 32 for every 100,000 purchased. So syringe and needle injuries are widely recognised, and safety devices have been successfully implemented as a prevention strategy in many facilities. However, this data shows that scalpel injuries still need more attention. There are 3 groups of consequences from scalpel injuries that can occur. The most common type is an uncomplicated scalpel cut. There is a tendency to dismiss these injuries as insignificant, but even a simple scalpel cut has costs. All scalpel injuries require testing of the injured staff member and potentially the patient, and post-exposure prophylaxis may be necessary. Nurses who have had to wait for blood testing results after sharps injuries also report negative impacts on their mental health. The cost for this type of injury was estimated to be as high as 4,000 Australian dollars nearly 2 decades ago. The cost would be much higher today. Serious scalpel injuries may require surgery, especially if an ulnar nerve, artery or tendon is cut. Up to 3 months of rehabilitation is required after microsurgery to ensure good functional recovery. The cost of this injury was estimated to be as high as 160,000 Australian dollars. Again, that was 2 decades ago. Finally, in a worst-case scenario, a scalpel injury can lead to a blood-borne infection. The most common blood-borne infections transmitted by sharps are hepatitis B, hepatitis C, and HIV. HIV treatment is a lifelong requirement. On this slide, the seroconversion rates of blood-borne infections from sharps injuries can be seen. This information is taken from the World Health Organization. For hepatitis B, the seroconversion rate is 1 in 3. Fortunately, the risk has been minimised through mandatory hepatitis B vaccination programs like those in Australia. The risk of seroconverting to hepatitis C is also high at 1 in 30. While hepatitis C is now curable with new treatments, this treatment is very expensive and can result in a number of side effects. The risk of seroconverting after HIV exposure is 1 in 300. HIV can have chronic impacts on health and well-being and requires ongoing treatment, which can cause significant emotional and economic burden. To bring context to these statistics, let's take a look at the human response to a sharps injury. The injured healthcare worker suffers from hidden costs, including distress, which can impact their families. Other case studies have found sharps injuries can cause clinical depression and even post-traumatic stress disorder. In addition, they can suffer from lost income and may become responsible, at least in part, for the financial burden of their therapy. Patients may also be impacted as they may need to undergo extra blood tests, can have their procedures delayed or cancelled, and in rare cases can run the risk of an iatrogenic infection. This is where a doctor or a nurse is unknowing unknowingly infected with, say, HIV or hepatitis C. And when they suffer a sharp injury, their blood enters the patient and can result in an infection to that patient. Finally, there are consequences to the facility. The facility usually has to bear the costs of blood tests and treatment, and will need to deal with rostering issues, understaffing, and workers' compensation. We sometimes refer to these three sets as hidden costs of shafts injuries, and therefore they are hidden savings for preventing these injuries. This was a very interesting case study from the Robert Wood Johnson Hospital in New Jersey in America. When one of their staff members contracted hepatitis C after a shafts injury, they calculated that the cost to manage this injury was about $324,000. In this, it was $81,000 in direct costs and $243,000 in hidden costs. But then, based on their 3% profit margin, they calculated how much revenue they would need to generate to cover this cost. It came to nearly $10.8 million. I would like to pause for a minute so that we can remind ourselves of why all this work is being done to reduce shafts injuries. To do this, we would like to put a human face to one of these shafts injuries with a quote from a young US nurse. I wanted our turnover time to be within expected limits. So as we were finishing up, I took my needle holder, grasped the used blade and took it off the knife handle. I successfully took the blade off, but I also cut through both layers of my gloves and part of my finger with it. Stunned by what had happened, I stared at my ripped gloves covered with blood. I didn't even feel myself being cut. I felt so stupid for cutting my hand over something as simple as taking a blade off a knife handle. Even stupider because it was a used blade. The mental blow of embarrassment overwhelmed me, and I instantly apologised to the surgeon and the team. And that's a quote from Sam Ganavan. This injury happened to Sam 2 weeks after the hospital had reviewed an engineering control to prevent such injuries, and they decided they couldn't afford it. Pardon my cynicism, but I'll bet that if this was to keep a patient safe, they would have found the money in a heartbeat. I will hand over to Shreya to conduct our next thought experiment.
We are at the point of doing our second thought experiment. Dr. Sinnott has just shared this extensive data on Sharp's injuries. So I want you to think about this data on Sharp's injuries in operating rooms. And I want to ask you, who is convinced that Sharp's injuries are a real problem that we need to work on? Yes, do you agree? Or no, you think there's other problems? You can answer it in the chat. And I also want to pose an additional question. So for those who are not convinced, what do you think you need to be convinced? So A, if you're convinced or not that it's a real problem, and B, if you're not convinced, what do you need to be convinced?
Okay, thank you, Shreya. Camille, do you want to speak? Camille from Turkey. Dr. Nico, please raise your hand and speak. Camille first, will you?
Hi.
Please.
I think
Yes.
this is important situation.
Thank you.
Thank you. And I completely agree with you, Kemal. And I've seen a lot of people, over 10 people. Actually, people are on saying, agreeing with you completely, even in the chat, saying that yes, all agree essentially that Sharp's injuries are an important role to look at. So thank you everyone for participating again and agreeing with how real and big a problem it is. I'm going to pass it back to Dr. Sinnott now.
Thanks, Shreya. Like you, we also agree on Sharp's injuries being an important problem to solve in the operating rooms. For this, we have developed a global approach of tackling the issue on 4 levels that we have developed to explain what is needed to reduce Sharp's injuries in our operating rooms. The first level is the government level, and this involves legislation and/or standards. The second level is the level of the professional bodies, such as those representing surgeons, operating room nurses, and infection control specialists. These bodies need to update their own Sharp safety guidelines based on the latest evidence and updated legislation. The third level involves the healthcare facilities per se. This involves in updating their policies and implementing the required changes. The fourth level is that of the end users. They must be provided with the latest evidence and hands-on training with new safety engineering controls. Before I move on, I would like to share with you our 2 other key observations. Firstly, updates need to occur at each level simultaneously, not one after the other. Secondly, these 4 levels are not very good at talking to each other. This is where SAPS does a lot of work, including at meetings like this, where we share the latest evidence with all 4 groups. Let's now see what the situation is in my home country, the Australian story. The Australian Standard AS 3825-2020 is the revised Australian standard for safely removing, containing and disposing of used scalpel blades. The standard states that healthcare workers shall not remove used scalpel blades with their hands, with artery forceps or needle holders, and they shall not use devices that have a resheathing or 2-handed type action. The standard specifies that scalpel blades should only be removed and contained using a single-handed scalpel blade removal device. The immediate containment requirement is new. It is designed to protect downstream workers from Sharp's injuries, as they suffer anywhere up to 25 to 35% of all Sharp's injuries. Now, while using artery forceps and needle holders to remove blades has been the norm for many clinicians, this is no longer allowed in many, if not most, countries. Shortly after the publication of the Australian Standard, the National Health and Medical Research Council, NHMRC, updated their Australian guidelines for the prevention and control of infection in healthcare to include the need to use safety devices to minimise the risk of injuries, including single-handed devices to unload needles and scalpels. 2, to highlight that safety devices should prevent injury to the user and to others who may encounter the device during or after a procedure. That is, that Sharp's injuries should be immediately contained. And next, that passive safety devices, which are the ones that activate automatically, should be considered where appropriate. This is in contrast to the active safety devices that have to be manually activated, thus inviting the risk of human error. So, after we addressed level 1 and level 2, the professional bodies' guidelines were updated. So, following the publication of the Australian Standard and the subsequent NHMRC guideline updates, a number of professional bodies in Australia have revised their own Sharp safety guidance to their members through updated standards, guidelines and recommendations. This has included, but is not limited to, the College of General Practitioners and, of course, the Australian College of Operating Room Nurses, and even APRA. APRA stands for the Australian Health Practitioners Regulation Agency. It also requires adherence to the NH and MRC updates. So next we will look at how effective these first 2 levels on their own can be. This Australian case study shows a 3-fold increase in the use of safety devices after the publication of the standard. We will now look at what has been achieved in America. The Needle Stick Safety and Prevention Act was signed into law by President Bill Clinton in 2000. This law mandated that the Occupational Safety and Health Administration, known as OSHA, revise its blood-borne pathogen standards. OSHA is part of the US Department of Labor. It was created to ensure safe and healthy working conditions for workers by setting and enforcing standards. They cover all workers in all industries, but the blood-borne pathogen standards apply mainly to healthcare facilities. In response to correspondence from staff and patientsafety.org, OSHA has published 3 letters of interpretation as a means to update their blood-borne pathogen standard. And as you can see by the 4 circles, OSHA's recommendations now mirror that of the Australian standard. There are professional bodies worldwide that represent healthcare workers and ensure compliance to the national legislation and standards. In America, we can see the response from their professional bodies. Both the Association of Perioperative Nurses and the Association of Surgical Technologists have updated their SHARP safety guidelines and policies to ensure that they are compliant with OSHA's blood-borne pathogen standards and the updates that OSHA have made through their letters of interpretation. As you will remember from an earlier slide, America has seen a drop in SHARPS injuries of about 31.6% outside the operating room. I will hand over to Shreya again to conduct our next thought experiment. Thanks, Shreya.
Thank you, Michael. So looking at these guidelines that Dr. Sinnott just told us about for protecting clinical and other staff, such as accreditation auditors, would you find these guidelines helpful in your work? Yes or no? If anybody wants to answer, they can answer, or in the chat group as well. We already have a few messages in the chat. Yes, Dr. Hani, you were saying?
Yes, please answer. So many answers, yes.
We have a Michael, we have a resounding yes from the majority of our participants.
Thank you, Shreya.
So back to you. Thank you, everyone.
As you will probably have noted, the US legislation was passed 25 years ago. And as you would expect, a lot has changed in recent years. In the next section, we will share with you a summary of the latest evidence that has been used to update the US legislation, the Australian standard, and professional body guidelines around the world. Firstly, it is important to note that not all safety engineered devices are the same. They are not all as effective at reducing SHARPS injuries. Safety engineered devices can be broken into 2 main categories. Firstly, a passive safety device is one that is activated automatically. Examples include a spring-loaded safety syringe and a single-handed scalpel blade remover. As you would expect, these passive safety devices offer superior safety. 2, an active safety device is one that needs to be activated manually, inviting the inevitable risk of human error. Examples include an old-fashioned safety syringe using a cover that needed to be pushed over the needle and safety scalpels. A multi-centre French study found that active safety devices caused 70 times more injuries than passive safety devices did. You may remember that the updated Australian standard included the new requirement to include the need for immediate containment of the removed shaft. This was included because it is estimated that up to 25% of all SHARPS injuries occur to downstream workers. This means if a scalpel or a needle is left on a surgical drape, it will go to the laundry and a worker there may suffer a shafts injury. The hierarchy of controls is the next one I'd like to talk to you about. It was developed back in the 1960s to replace the behavioural model of staff safety that relied on changing human behaviour, and as you would expect, it was not very successful. The hierarchy of controls is divided into 5 levels. Elimination is the removal of the hazard, and this is obviously the best way to prevent a bad outcome. Substitution is next. It is the replacement of the hazard with a safer alternative. The third level is engineering controls, and these are designed to further protect from hazards by creating a change to the worker's environment. Administrative controls ensure that staff change the way they work and that implementation of the control measures is successful. Personal protective equipment is the last line of defence and is considered the least effective control measure to protect from hazards. Over recent years, the hierarchy of controls has been adopted by more and more healthcare facilities, governments and regulatory bodies. We will go through this very quickly, one by one. So we can use the hierarchy of controls to make our environment in the operating room and elsewhere in the hospital safer for all staff. Starting at the top of the pyramid, let's look at the most effective way of making the work environment safe, namely elimination. For other shafts injuries, such as needle sticks, we could eliminate unnecessary injections, for example, switching from intramuscular antibiotics to oral preparations as soon as possible. For scalpel injuries, elimination controls are not applicable unless we start performing psychic surgery. The next step is deciding on and implementing substitutional controls. To reduce needle sticks, one can use needleless IV cannulas, and these are pretty much the standard of care now. To reduce the risk of scalpel injuries, substitution could include considering the use of diathermy or laser for skin incisions, but this is difficult to use internally and is associated with other risks to staff. For example, the need to use smoke evacuation and laser protection eyewear. To reduce the risk of suture needles, blunt-tipped suture needles are proven to be effective. They can be used to close muscle and fascia, but unfortunately, for reasons I don't fully understand, their acceptance has been minimal at best. Next on the hierarchy is the use of the use of safety engineered devices to prevent needle stick and scalpel injuries. They should be passive, which means the engineering controls should be automatic. They should also immediately contain the shaft to protect downstream injuries. Examples include spring-loaded retractable syringes and single-handed scalpel blade removers. And it's important to note that in Australia, engineering controls are the key focus of the NH and MRC guidelines when it comes to scalpel safety, as they are the most effective practical level under the hierarchy. Next level down on the pyramid is administrative controls. Administrative controls include writing an exposure control plan, banning recapping, ensuring neutral zone or hands-free passing techniques are used, and safety training programs for all staff exposed to shafts, including ancillary staff. This can be done through apps and other platforms. Shafts injury reporting and investigation processes are also very important. In summary, the administrative controls are a good way of ensuring that the higher levels of control in the hierarchy are being implemented. It is worth reminding ourselves that PPE sits on the bottom of the upside-down pyramid for a reason. It is the least effective way of dealing with the hazard. It can be thought of as a last resort. So PPE should always be used in conjunction with the higher levels of controls and never as a substitute for them. Examples in PPE include safety glasses, face shields, double gloving, and protective footwear. I'll now hand over to Shreya for our final thought experiment.
Thank you, Michael. So I just want to ask the team one final question regarding the hierarchy of controls. And I already see the answers rolling in. Have you or your team used the hierarchy of controls as a way to minimize harm and damage or incorporating change specifically before? Yes or no? And if anybody wants to answer how they used it, we'd be happy for them to share their experiences too.
There are so many answers already. Very quick.
Yes.
Everybody is yes. Some are not yet, Dr. Arif.
Okay. We've gotten a lot of yeses again, Michael. If anybody wants to say anything about their use of hierarchy of controls, you're welcome to share with us.
Yes, Dr. Who still not yet? Maybe you can speak up.
Or we could do it in the Q&A and we'll be finished shortly.
Yeah, okay.
Thank you.
Okay.
Back to you, Michael. Thank you.
We would now like to share with you 3 core innovative tools that can be used to improve both staff safety and patient safety. The first tool relates to the expansion of the World Health Organization's surgical safety checklist. To put this into perspective, let me share a quick personal story. After presenting at AORN last year, I visited a friend and colleague of mine, Dr. Mark London, in South Carolina, where he is the director of the Vascular Access Unit. Mark invited me to scrub up and observe the cases he was going to perform. This was very interesting for me, as I had not been inside an operating theatre for the best part of 20 years. And it was also interesting because the procedures he was performing that afternoon had been performed on most of the renal patients I had looked after when I was doing my physician study. So the first thing I noticed in the operating theatre was that the surgical team carried out the surgical safety checklist at the start of every case. It was quick and decisive, and there was no resistance from any of the team members. Then during the second case, the scrub nurse looked at me and said, "Michael, you might want to step back a bit. This next part of the procedure might spurt a bit." So I took her advice and stepped back. And then, non-judgmentally, she said to the room, "Why isn't Michael wearing a face shield?" And I had never thought about putting on a face shield. I hadn't been in an operating theatre for 20 years. This happened twice during the afternoon. So afterwards, I thought about it. We've got these checklists for patient safety that are proven to be effective. They're proven to improve both mobility, to reduce both morbidity and mortality for patients in operating rooms. So I thought, why shouldn't we have 1 or 2 safety checks to improve staff safety? It would be very easy to add to the checklist before the operation started. Is there smoke evacuation in place if necessary? Are single-handed scalpel blade removers ready to protect staff? The second idea that we came up with was a safety score audit. This innovative tool was originally designed with accreditation auditors like yourselves in mind. The idea was formulated after I visited a small surgery centre in the United States after the Needle Stick Safety and Prevention Act was passed into law. I asked the owner whether or not he had any safety syringes. He smiled wryly and went to a small storage cupboard and returned with a single box of safety syringes. He literally had to brush the dust off the box. He explained that if he was ever inspected by OSHA, that he would pull this box out and show to OSHA that he did in fact have safety syringes, even though his staff weren't allowed to use them. Obviously, this person was playing games to beat the system, but in doing so, he was exposing his staff to sharps injuries. So when I thought about it a bit more, it occurred to me that if the OSHA auditor had asked to see how many syringes he had bought each year, he or she would have had a much more accurate idea of whether or not the safety syringes were being provided to staff to use to keep themselves. If he was only buying one box every 5 years, it would be obvious that the staff weren't using safety syringes, as the law required. Thirdly, we have proposed that using the information available for free in our purchasing data software and using artificial intelligence to produce smart reports for clinicians to use to improve staff and patient safety. This would broaden the use of purchasing data to include clinicians as well as auditors. A staff safety example would be one focused on reducing the risk of shaft injuries. So this time imagine you are a charge nurse in the operating theatre. Each Monday you would get a report on both the number of scalpel blades and the number of scalpel blade removers that you had been sent from the supply department the week before. The AI generated report would say if there was a disparity, for example, only half the number of blade removers compared to scalpel blades. This would then need to be investigated further and acted upon immediately. This would be much safer for everyone than waiting for a scalpel injury to occur first and then investigating it after the proverbial horse has bolted. A patient safety example would be focused on reducing the risk of iatrogenic infection. Let's imagine you are the director of the infectious diseases unit in your hospital. Every Monday morning, you would get a report of how many bars of soap every ward had received from the central store the previous week. The report would do the analysis for you as you are very busy. The report would say Ward 5D did not buy any soap last week. This would raise alarm bells, a possible leading indicator of a potential infectious disease outbreak on Ward 5D. And an urgent visit to the ward would be arranged to prevent an outbreak happening. It won't take long for you to think of multiple ways in which this data, in the purchasing data, could be used to help conduct hospital accreditation audits and improve both staff and patient safety. To conclude today's presentation, I would like to hand back over to Shreya. Thank you, Shreya.
Thank you, Michael. So to conclude, we would like to share our vision for the future, which is a one safe culture for all, that's staff and patients. And after that, we will open the session for any questions and answers. So, a pair of artery forceps were left in the patient's body after instrument count was completed, but before the patient leaves the operating room. Who thinks that this is acceptable? We have a checklist to prevent an incident like this from reoccurring. Now look at the staff safety case. Who thinks this is acceptable? One injury is one too many, and we will look at our proposal for the future. Patient safety has always been important and for good reason. Clinicians by nurture and by nature have almost always prioritized their patients over their own safety, and this is often reflected in systematic improvements as well. So in the last few years, especially with the pandemic, we have seen this shifting and staff safety being somewhat integrated with patient safety improvements. This is largely driven by clinicians like yourselves and people like yourselves speaking up and taking the time to run programs like today. However, there is still a long way to go where both staff and patient safety is part of a one safe culture, and this is what we want to work for. The next major step to achieve this one safe culture for all is to acknowledge and share that staff safety is the new standard of care. I would like to thank my co-authors, Dr. Michael Sinnott and Dr. Chamandika Kunara, and to invite anyone with questions to contact me on this email address. And for now, we're going to open the session for a question and answer round. Thank you.
Thanks, Sean.
Thank you very much, Michael and Shreya. Please, who have answered, let us ask Dr. Nico Lumenta. He's the father of patient safety in Indonesia. Maybe he can give some comments. Please.
Yeah. Dr. Michael, we met in July, I think, in South.
I remember very fondly. Thank you.
Yeah. But at the time, my position is from the Indonesian Hospital Association, from the Institute Hospital Patient Safety Institute. Okay. What is the development of engineering control in the world? Hierarchy of control. One of them is the engineering control. What is the development now?
So I remember speaking to Karen Daly, who was a registered nurse in America. She was working in the Boston Children's Hospital, and she told me the story that she was working in the emergency department, and she told me the story at the end of a 12-hour shift, she felt very tired. One of her friends had trouble putting a cannula into a patient and asked her for help. So she went over and put the cannula in, but in doing so, she spiked herself with the cannula. She was very tired and all she wanted to do was go home and go to bed. But her friend, who was now feeling very guilty about the sharps injury, insisted that she have the blood test taken and that she report the injury. Sadly, she contracted both HIV and hepatitis C. Anyway, after the treatment, Karen Daly went on to do a PhD and became president of the American Nurses Association, and she was one of the driving forces to get the American Congress to vote into law the Needle Stick Safety and Prevention Act. She told me at the time one of the concessions made to industry was that the safety devices could be just an addition to their already set up manufacturing process. And that's why the first round of safety devices that we saw are what we call active safety devices, which require human effort and therefore run the risk of human error. So the simplest one, and I'm sorry I haven't got a syringe with me, but if you imagine that that's the needle, then the safety device was on the side here and you had to push it across to cover up the needle. And obviously that's very risky because you can very easily hit the needle with your finger. And so over more recent times, what are called passive safety devices, which are automatic and don't require any human innovation, have been developed. And as with most things, as they're developed, as they're used more and more often with increased volumes of manufacture, the price of these have come down. They're still more expensive than an active safety device, but they are definitely much better at protecting staff safety. So that would be one of the biggest recent innovations, namely the development and uptake of passive automatic safety devices. Thank you, Dr. Nico.
Thank you, Dr. Michael.
Thank you. If there's no question yet, I will have one question to you, Michael. We are talking about patient safety. It's already done everywhere. And now you are talking about staff safety. Yeah, we have a very big problem with staff safety during COVID. But there's another field that we have that we need to care is the environmental safety. Because before we use needles, metal needles, it took 100 years to dissolve. Now we use plastic. It's cheaper, but it's also very difficult to disappear in the world. So I'm afraid if we use new equipments and then they are not very safe to the environment. What do you think?
Dr. Hannah, that's a very challenging question. I'd like to give you three answers, if I can remember all of them. Shreya and I both presented at I think it was the Victorian Nurses Victorian Perioperative Nurses Association in Melbourne a few months ago. One of the speakers was an anaesthetist who spoke about this very topic. And the anaesthetist pointed out that reducing waste was important, but for environmental sustainability, the energy costs and other costs of every operation is very significant. And she said that research showed that up to 15% of all operations probably should not be done. And so I think the first thing we need to do is make sure that before we do a test or before we do an operation, it is in fact the best thing for the patient and not just a hopeful thing for the patient. The second thing is that when it comes to using reusable or materials that will dissolve in the environment more quickly than current plastic does, we're seeing the greatest uptake there in Europe. Europe is making it very, very difficult for manufacturers to sell the standard products. Australia is starting to think about that, but places like America still have a long way to go. And it's only when the purchasers demand that level of improved environmental sustainability that manufacturers will respond. And the third thing relates back, in my mind, to the mad cow disease. So we'll all remember the outbreak of mad cow disease in the UK. So mad cow is caused by a prion, which is very hard to kill with sterilisation. So I think that is one of the factors that led to a big uptake in the use of single-use disposable instruments. At the hospital, when I was still working, we went through a phase where we were buying metal instruments from Pakistan, for example, for sutures. And at the end of the procedure, everything was thrown in the bin. Whereas what should be happening is better quality instruments should be used and they should be re-sterilised. And the other thing is, if you take, for example, a plastic passing tray in an operation, at the end of the operation, that plastic passing tray will be thrown in the bin regardless of whether it was used or not. We need to go back to where lots of instruments and lots of containers in an operating theatre could be re-sterilised and reused. So they'd be three things that I think we should all be considering.
Yes, thank you. We have two more questions here. Do the writer is going to read themselves or we will read it for you? NTT Clinic, Vincent, is the personal protective equipment from scalpel injuries single use or multiple use? Is the personal protective equipment from scalpel injuries single use or multiple use? The one you talk, Michael.
Shane, do you mind if I answer that question? The first thing, and it took me a long time to realise this, the scalpel blade remover is not a personal protective equipment. The scalpel blade remover is an engineering control. So it's third on the hierarchy of control, well above personal protective equipment. And so of the devices that we're aware, a scalpel blade remover will be multi-use, used multiple times, multiple patients, etc., in the non-sterile environment. However, if you're using a scalpel blade remover in the sterile environment, it by definition will have to be used only once. It can take off multiple blades, but it can't be reused on another patient.
Okay.
I hope that's clear.
Yes. So there's another question from Shirley, Hospital Tibet from Jakarta. Is the double cross-check to release the bisturi should be in the sign out list? I mean, how to release or disconnect with the right way, because when we talk about sharp injuries, maybe it can be the preventive way to do.
Could I just double check? Did you say, should we use artery forceps? I didn't hear the first bit, Dr. Hanning.
Yes. She said to use sign out list to put a double cross check to release bisturi, to release the scalpel. Or she said, what if if we make a preventive way, other preventive way to stop sharp injuries?
Thank you very much. So it's interesting that a few years ago, 6 out of 10 nurses in America would admit that they would still occasionally, for example, if they rush, use fingers to remove scalpel blades. And if you ask anyone in normal society if they think that's safe, everyone would tell you no. The next thing is with the needle holders and artery forceps. That's been the most common practice for many years, but it is also involved in scalpel injuries. And OSHA in America has said that you're not allowed to use needle holders or artery forceps. So they're all encouraging a single-handed scalpel blade remover to protect the staff.
Oh, yes. Okay. Anyone else to ask? You can raise your hand or just talk.
Dr. Hani from Turkey.
Yes. Oh, doctor. Oh, yeah. Please sit. Please, you can talk.
It's in the chat.
It's in the chat. Wait a minute.
I'm happy to read it. Kemal from Turkey acknowledged that how in Turkey patient safety is supported through a nationally implemented reporting and monitoring system for adverse events and near misses in healthcare. And the system allows healthcare institutions to systematically report incidents related to patient safety, including medical errors, falls, medication errors, inspections, and other safety-related events. Thank you for sharing that. We think that is excellent, but it's also important to have specific guidelines for sharps injury prevention, which now increasingly is being done worldwide. Michael, if there's anything to add, please do.
You talk to Heron now. I think what you've pointed out is extremely important. One of our beliefs is that the tools we use to improve patient safety should also be able to be used for staff safety, and the tools we use for staff safety, in particular in other industries, can also be used for patient safety. So what you've identified is the fact that we need to report injuries to improve patient safety. So what we need is a parallel, if not overlapping, system where we encourage staff to report staff injuries. Then the reported staff injuries can be analysed, and systems to prevent those staff injuries in the future can be developed. And so what we would then be seeing is that staff injuries and patient injuries go into one big box where they're analysed, and the output would be the same to improve staff safety and patient safety. Thank you.
Thank you, Michael and Shreya. If there is not
one more question.
One more question from Dr. Nico, please.
Yes, Dr. Michael. I'm talking. I'm discuss about safety audits. Safety audits quantitatively. As we know together that WHO, a new paradigm in 2021, the Global Patient Safety Action Plan, is that no one should be harmed in healthcare. So it's included of course, staff. But with the broad paradigm, now can you talk about the safety audits qualitatively or quantitatively? Thank you.
Thank you very much, Dr. Nico. This is an idea that we had, I can't remember, 10 or 15 years ago. And it's very simple. So the purchasing data contains an enormous amount of useful data that we have no contact with, despite the fact that it could improve staff safety and patient safety. One of the big problems when we first developed the concept was that in those days, the raw data was not very clean. And as most of us will remember, there was an old saying when computers first started to be used. And that saying was garbage in, garbage out. So if the data in your purchasing software was not consistent, it was not able to be used. Shreya and I were both asked to present a few weeks ago by the Ministry of Health in Malaysia, and they actually gave us the topic using artificial intelligence. So when we did some research on that, we combined what we learned there with our old idea of the purchasing data. So we now know that every medical device in the world has a unique GITN number. So that means when your hospital purchasing department buys products, and I obviously buy thousands every day, when they put that into their system, each product can now be identified down to the colour of the device. So all of a sudden, the garbage in problem has been solved. So now we have data that could be produced, even in a spreadsheet, and given to a clinician. The problem is that would then take the clinician a long time to analyse, and all clinicians are very busy. So we now have the opportunity to develop simple AI software to analyse that good data and produce reports that will be clinically relevant and can be used almost daily. And the idea here is to predict a situation where an injury can occur, and I think the experts call that a leading indicator, and that can then be acted upon before the injury or the bad outcome occurs. And if CARS or any of your hospitals in Indonesia would like to develop that further and do research on it, we would be very happy to participate in that.
Okay.
Yes, thank you very much, Michael Sennett. We also ask you if you have some broad experimental research about this. You can please take us with you, because we are so many hospitals here and so many fixed hospitals and so many patients, because we are such a huge populated country. Michael, in Indonesia, we are deeply aware of the sacrifices made by the healthcare workers during COVID-19 pandemic. At a time when the path forward wasn't clear, but through the research, that are nearly 2,000 healthcare workers die during the COVID-19 pandemic. To receive 640 doctors, 637 nurses, 377 midwives, 98 dentists, 34 nutritionists, 33 lab technicians, 13 public health experts. So nearly 2,000, and it's a very huge burden to us. Yeah, we send a huge thank you to Dr. Michael Sennett and Professor Michael Sennett and Professor Shreya Singh for your insightful presentations, especially for the slides in our Bahasa, in Bahasa Indonesia. That's superb. This is the first time for us, and that as a presentation in our language, and you talk in English. Thank you very much for your concern to us. Thank you very much. I hope that everything will be good to you, and God will bless you all.
Thank you, Dr. And we would
Thank you,
like to
Dr. Hanna.
thank Dr. Hussain for helping with the translations.
Yes.
Yes.
Okay. Now, Dr. Sutopo, will you give your closing statements? Dr. Sutopo? Or maybe Dr. Nico?
Dr. Hani aja udah, langsung aja moderator.
Yes. Yeah, okay. So we are very grateful to these two professor speakers, and we hope we still have connections to grow further. The staff safety is becoming a new item here in Indonesia, but it's not yet in the rules. Maybe we can work together because you have also connections with the MOH. Please, Dr. Johnny, close our session with your prayers. Dr. Johnny? Oh, he's going away. Maybe okay then. Thank you very much. We are very grateful to you, Michael. Have a very successful future, and God bless you all. Thank you.
Thanks, Ryan.
Okay.
Good night.
Good night.
Bye-bye. Yeah, friends, don't forget to fill in the name the presenter, because we are going to send the certificates, and also if you want to download the presentation of Michael and Shreya, you can download it. It's already in the chat. Thank you very much for all. Can you put everybody in the screen so they can wait?
Thank you. Thank you so much.
Yeah, okay, come on.
Thank you so much.
Thank you so much.
Thank
Coba
you,
dibuka.
everyone.
so
Good
much.
night.
Layarnya
Thank you
dibuka.
so much.
Thank
Love
you.
you.
Bye-bye.
Ya.
Thank you so much.
Thank you.
Oke.
Good night.
Terima kasih, sampai ketemu di international meeting yang akan datang bulan depan. Terima kasih.
Terima kasih.
Terima kasih.
Terima kasih, Dr. Hani.
Dr. Hani.